move forward with, introducing Dr. Agnihotri, who really needs no introduction. I mean, he is one of the people who helped form this group and instrumental in coming up with ideas to put this together and to bring people here. And so, he now, unfortunately, has left us for more fertile grounds in San Diego. And, as you may know, he transitioned out from Mercy Medical Group as a medical director and is now, working and has done a great job in the sharp Rees-Stealy Medical Group in San Diego, who has performed at the highest level and has gotten the awards as the first physician organization to hit all the goals of the Right Care Initiative. So they've done a tremendous job down there with Parag's direction. So I, again, wanted to thank him. He's going to help give us some pointers as to how they did it down there. This is about sharing best practices and about finding how to improve the care we provide to our Sacramento community. So without further ado, thank you, and Parag.
And while they get the computer set up, I'll just let you all know that we would really love to have you take advantage of the continuing education while you're here. If you participate in Right Care meetings all year, you can pretty much earn all the continuing education you need, especially if you come to our one-day summit, which will be scheduled for October 30th. So it's a wonderful gift from the Health Services Advisory Group, and it's a lot of work for them to do the continuing education. So please go online and get your credits. There's no charge for you to do that. And with that, Dr. Agnihotri, who I want to mention is also designated by CMS as an innovation advisor for the state of California. Dr. Agnihotri will wow us with his wonderful presentation about how he hit the A grade for every single one of our clients. So thank you for being here.
So thank you, Hattie, and thank you, Jose, for this wonderful introduction. Good afternoon, everyone, and I'm very excited.
I'm playing my best card early. Now you can take as much time as you want.
Oh, okay. Okay. No, sorry. It's very exciting to be back here, to see back in Sacramento, to see my friends and colleagues, and I think because of that excitement, I was able to bounce back from my viral illness last week. And so thank you for scheduling it so that I could get better faster. We just want to share with you, this is a learning network, and we want to share with you how Rees-Stealy did with its advanced perfect care for diabetes. A lot of credit goes to Dr. Jerry Benso, who was my predecessor at Rees-Stealy, who really started the program. But what I want to share with you is over the past 1.5 years, how has been the journey in managing the variation in diabetes and hypertension and truly aligning with the Right Care Initiative goals, and that's what we are here for. This is a beautiful room, beautiful meeting. The first time when we started the meeting here, and I was really impressed by this place. The food is always good here. So that's very nice here. But I just want to share those people who haven't had a chance to visit San Diego, the meeting location. This is where it is held. I think it's, for me it's very distracting actually, because I see the view outside here when I'm sitting in the meeting outside. I'm seeing the surfers and the dolphins and the seas, and I don't know how I'm going to get any work done but in this meeting room. But University Best Practices in San Diego is a similar collaborative. I think you have attended those, and I think we tend to learn from each other, and what happened in Sacramento also helps us to get better down there. So with that, I just want to share that Rees-Stealy Medical Group is a multi-specialty medical group based out of San Diego only. And as like any other medical group, we also have the challenge. We have to address the changing demographics. We have to be proactive in team-based care. We have to align with the payment reform, and we have to embrace the changing healthcare delivery system. When we're looking at all these things, it comes down to, boils down to a three-part aim, which we all know very well by now. Dr. Don Berwick ITES-AAA, which CNS has adopted as a three-party, is to provide the best care for the whole population at the lowest cost. And if any program, if we do any chronic disease program, we align it with this, we will be successful. So Rees-Stealy has been, similarly has been successful in controlling diabetes. When we look at diabetes bundle care, which is the all or none perfect care for diabetes, for commercial population, Rees-Stealy is almost at the 90th percentile, 47% control. That's for commercial population, which places us in the top 4 in California, and that's why we got our RCA award. But we also look at other payers. It's not just commercial insurance. In our data mart, we have Medicare patients, we have PPO patients, and any other payers. So anyone who's diagnosed with diabetes gets into the data mart, and we manage the patient same irrespective of their payer class. And when we look at that, in fact, performance is higher. It's actually 52% control rate, which places us above the national 90th percentile for any kind of payer you want to take. So when I say bundle care, what do we mean? We mean it is a rolling 12 months, 80 to 75 years of age. If A1C has to be less than 8, LDL has to be less than 100, blood pressure has to be less than 140 by 90. Before the criteria was less than 130 by 90, we relaxed it to a few years back, 2012. And the annual nephropathy screen, which means either you take urine microalbumin or you have an ACE or ARB. Now, any of you who has participated in this program knows that you could have 80%, 80%, 80% control on each of these. But when you combine them, your bundle rate goes down dramatically to 40%. So to have almost a 50% control, you have to be at least 85% plus. In fact, sometimes 90% control for each of these measures to get that. So this is the journey. This is the journey for Rees-Stealy on all-on-one diabetes bundle care. At one time, it was around 26% control. There was a change in blood pressure criteria which increased the baseline rate. And the goal late last year was 48%, but right now, the whole population is at 52% advanced perfect care. I just want to share with you how this was achieved. What were the challenges? How did the practice variation? I just want to focus a little more on the practice variation part and how we address that part. So I think in any program, any quality program, I think what we would like to do is to basically take you on the board, see those things, the arrows. That's what I think the theme will be. How do we align stakeholders, look at workflow, team-based care, patient engagement, healthcare reform, total cost of healthcare lessons. So that's what I'll be touching base on. So first important thing is always align the stakeholders. And I think as any of us know that any program you go forward and start it, that if your stakeholders are aligned, you'll have this and these results where people the outcomes will not what we want it to be. So here's a question, and I think for us in this group, and I hope you have the interactive clicker there. And Ruby is my Wheel of Fortune system, but she's going to help us out. But what is the average prevalence of diabetes in Sacramento, Yolo County? And this is based on 2009. Yeah. It's only, I think we have 40 clickers out there, and I have 19 responses, so 20 of you are not participating.
Please make sure that unless you need to have one, give it to one of the members.
Does everyone have a clicker?
Does anybody not have a clicker who wants one? I see that we need one over at this meeting. Dr. Jambroni needs one, please. Thank you. Thank you, Ruby. And then you would just make sure that Carlos distributed all of them. That'd be great. How many responses do you have now?
21. Okay.
21.
Oh, come on. This is a friendly thing. There's no, I'm not going to send your quiz results to President Obama.
No, who's got the answers, right or wrong? It's just
Anyway, so I think, I think we are having more people respond, so that's good. Click next. So there is, let's see, Okay. Very good, very good. So I think 65% of you said 6% of the population, and that's correct. Because I think if you look at Sacramento, this was a older data, 2009, at 6%. But if you take it to the next this thing, if you take a look at the CDC data, which is showing how the prevalence of diabetes is going up, right now in the whole country, it's almost 8.5% of the patient, and this is still old. And I think all of us know in the past few years, I can bet you that the number of people with diabetes is going up every year. So with that, I think with those numbers, when we look at San Diego, almost 8% of the central, south, and east San Diegans have diabetes. And around 28% of people have hypertension. Today at Rees-Stealy, in the medical group, we have 17,000 patients who have been diagnosed with diabetes and who are no data mark. Huge number, 17,000 number. So now, if you are responsible for the cost of most of these patients, what would be the cost? The second question comes is, what is the total annual cost of healthcare for an individual with diabetes? So let's take a guess. Total average annual cost for an individual with diabetes. All right, so we have a lot of responses here, so people are finishing their food. So the answer is correct. Majority of you got it correct. Almost $14,000 is the average annual cost for a patient individual with diabetes. And this was based on an American Diabetic Association study done in 2013, which said that around $13,700 is the annual cost, of which $7,900 is directly attributed to diabetes, of which 43% is inpatient cost, 18% is to treat prescription medication, treat complications of diabetes, like Avastin or something. Or 12% is only antidiabetic agents, which is, if you think about it, metformin is very, very cheap. I'm sure the pharmacist colleague will agree. And physician office visit at 9% and 8% is nursing or residential facility care. So majority of the cost is coming from hospitalizations related to complications related to diabetes. Now, if you're responsible for the cost, and our medical group, 70% of revenue comes from our capitation dollars. 230, if you have to, do the math, 70,000 diabetic patients, $14,000 cost, almost $200 million annual cost for diabetes. If somebody else was paying for it, fine, you would be good with it, you will continue to fee for service. But if we are responsible for some cost of it, it's our buck. So there is no reform without payment reform. So what we invest today, we hope that what we can invest today, we will reap the profits tomorrow by reducing complications. And it doesn't have to be capitation. CMS, I think Dr. Thompson is there on the back, has created wonderful programs now with CMMI, with ACO shared saving program, Pioneer ACO program, commercial ACOs, capitation, global payment, value-based payment. And some of you who are in FQHC in California, I'm sure are also participating in the medical home model payment. You have so there are so many payment models one can participate and get population health payments. And I think there has been studies done, there was a study done which shows that managed care organizations do a better job of managing diabetes compared to non-managed care organizations. So I think the first thing is always to align stakeholders. So in Rees-Stealy, the advanced perfect care is on the NTP scorecard. So on the, if you today pick up the phone and call our CEO, she'll be able to tell you what is our rate, what is the performance, and what are we doing about it. The CEO of the healthcare system sets up every year stretch goals to see what should be the performance of diabetes care. So now today you have the senior vice president of building and management also knows that diabetes care is an important thing for Rees-Stealy. The physicians know about it, the staff knows about it, so everyone knows that this is a part of this thing. So the first lesson is, let's get it on the balanced scorecard. So now we have on the scorecard, what do we do about workflows? How do we get it? How do we get 115 primary care physician doctors, 17,000 diabetes patients, 18 clinic locations, 2,000 clinic staff? How do we get them to really work on this? So this was the timeline on continuous. It's not that every time you set a program that things will automatically improve. There was a time when the goal was 40% and performance was going down. At that time, the main thing which was the performance was based on a workflow on a list which was sent to diabetes nurse managers and to clinic staff. Clinic staff means these are medical assistants who are in the clinic, in the primary care physician office, in the end, and their job was to sort of go through the list, all the patients and all those things. But is that enough? So how do you get the buy-in from more people? So as a quality improvement, our philosophy for any program, whether it be diabetes or depression management, is to have first disease registry, engage the physician, engage the patient, and engage the staff. This is the 4 things we try to do for every single, and it's the same thing we did at Mercy also. So disease registry, I don't want to spend too much time on registry because I think most of you know now, a few years back that was a hot topic, but everyone knows now how to build a registry. There are claims data, ICD-9, diagnosis, and if you don't, there are so many vendors out there who are trying to also sell the product. But then the other points are engage the physician. How do you get physicians to buy into this whole thing? So here's a question for the group. And it's anonymous, so I don't know if you're a physician or nurse or what your answer is, so it's okay. Your answer could be the effective way to engage physician in a quality improvement project. The five people who are holding back. So it's okay, nobody, the physicians will not know this answer. Very good. So let's see what that says. What did you think? The majority of you said, let's have a campaign to the patient directly so that they could, like the pharma, ask your doctor about Cialis the next time you're we think that it's basically simply outlining to physicians what they want to do. Physicians are smart, don't get me wrong. But still, when it comes to pop health, it comes to this thing, we have to really make simple outlines on what you want physicians to do. And this is, this was part of a leadership book also by Ralph Jacobson, which outlines few simple things, how to engage physicians. What do you want your physicians to do? Do they know how to do the work? Do they have the resources to do the work? And are physicians motivated to do the work? So having it on a scorecard helps it. We'll talk about resources, but also telling having a simple guideline on what physicians should be doing for the project is important. So the 3 rules of success for diabetes at Rees-Stealy is appointment every 4 weeks until you achieve a goal for A1C, lab every 4 weeks until a goal for A1C, titration of medication every 4 weeks until a goal for A1C. So the only thing they have to remember is 4 weeks, I have to get something done for this uncontrolled diabetic patient. He doesn't get the medications, take a lab, make sure they're seen in 4 weeks. 3 simple rules to manage diabetes population. Second is, I think to create group-specific clinic guidelines. There are many guidelines out there, but if we can get the guidelines to be part of your own specific guidelines, every group has their own culture, and every group has their own, ways of how to manage the formulary, medication, and all those things. And I think creating a group-specific clinic guideline is helpful. Today, in the EHR, any physician can go on the left-hand bar. There is a user support bar. If you're seeing a patient, you can go to EHR, click it, takes you to guidelines, takes you to diabetes, and you can see that this is the guideline posted. So in this way, what happens is normally you give an education tool at the point of care, but also it creates a standardizes some kind of practice and allows you to have some standardization.
Before you leave that slide, could you talk about how your group created your own customized guidelines?
So there is a guidelines committee. So we look at, combining these trichometry, reactive thyroid models, other things. So there is the guideline committee takes, all the recommendations from all the societies, and we invite a specialist, we sit down, hammer it out, and then create step by step and get buy-in, and then it's published and posted.
So the key is you get the buy-in when your own committee.
Yes, so I think you're right. So I think once you have your own this thing, there's more acceptance of this thing.
How often do you revise your guideline or have a revision process?
Yeah, I think that's a very good question. It comes out in every two, depends on when the next, so now, right now we'll have to do something about hypertension because the Jane's, whatever form of JNCA. So I think we'll have every 3 years. So the second thing is distribute the registry list, which we better be accurate. And registry list, I don't want to spend too much time, but you know that if it's not accurate, physician will take it and throw it out. Now everything, you have one wrong information, everything is gone. So be better, as accurate as possible. Provide as much information as you need so that people don't have to go to EHR and do a dumpster diving to find that one piece of information. So they have labs, it has medications, there's a next time appointment, and I think in one shot, patient, the case managers and the physicians know exactly what to do and what are the next thing, on which patients they should focus on. Then there is a whole peer review. For past few years, I think this has been well discussed, and I think more and more people have agreed the more you sunshine the data, you have transparency of data. So this is all electronically published. Everyone gets a monthly report to say how they are performing, how they're performing compared to their peers, and how are they performing compared to the site location. So one site is doing better than the other site. We can, same as UBT, we tend to learn from each other. If one side is doing good, they have to have instituted some practice. We tend to take it to the next practice, next side and apply it. So I think with all this, the disease registry, transparency of data, and engaging physicians, you can, the group was able to get to the goal of 40% last year. There was a scandal at the last minute, but we were able to get there. So, but when you start looking at it, and you start, start looking back, because you know that Einstein has said that insanity is doing the same thing over and over again and expecting a different result. So, there's a lot of work there. But when you start looking at the variation among the practices, and this is one snapshot for one clinic location, you see that there is a distribution, there is a wide distribution between people who are doing very good and some people who are not doing very good. So what happened was, I think when we look back for this bundle care, some of the doctors and practices did most of the work. And then the question comes is, why is that? Why is some of the doctors doing more and what some of the sites? So you start deep diving and you're looking into the issues and you find that one thing which is happening is that we are participating in many programs. Rees-Stealy today reports on 100 quality measures per year. And some of these are regulatory, mandatory, where you're participating with Pioneer ACO, Meaningful Use, Medicare Star, and Aetna ACO for around 180,000 patients. The number of measures is huge. The number of lists which go out to the doctors was high. The second thing, because of this, the performance continues to slide down. Again, you're going back, and you have your screen moment that you don't know whether you're going to improve or what's going to happen, or this is a very stressful time that time. But the other thing is, when we did a deep dive, we found that there was a silver list, which is one of the lists from the registry going to the staff. These are the medical assistants who are in the clinic, sitting next to the PCP, and their job was to call these people who have A1C high, blood pressure high, and educate them on medications, educate them about things. But they are so overworked with their own day-to-day clinic staff work. Their job is to keep the lights open. Sometimes keep the office running. And even though managers knew that this was part of their priority, still this is not the number one thing on day-to-day, and they were getting pulled to do different kinds of things because the clinic is short-staffed. So this was our break point. We found out that this was not working for us, And we had to do some political maneuvering and get these positions reassigned into population health into a central part and create a centralized command center. So we have now the 3 RNs, 2 care specialists who are basically medical assistants who are higher scope of license, and their job was now to sort of be centralized, and they were the ones running the list, and they are the ones who are operating it from a centralized process. And then there are 8 diabetes nurses who are at each clinic, major big sites, and we still left them at the clinic location because that's very important. Face-to-face interaction, being close to the doctor is really helpful. And these people bring back patients. They bring back patients into their own offices sometimes for following up with diabetes. And I'll go over what exactly their workflow is. So this was a centralized process. We created a centralized command center to manage about 17,000 diabetes patients.
Before you leave that slide, what did you mean not taking meds task physicians? Could you describe that?
It's, if the case manager, for example, the RN, she's looking into statin and the patient is not taking the medications, then we let the physician also know that the next time the patient comes, just don't increase the dose of the statin, just don't add another statin, because the patient might not be taking the medication. So that's what we're trying. So we're doing the whole calling the pharmacy and finding it out. So here is a simple workflow. The workflow for team-based care, so I'm now on team-based thing, is there are 3 lists which go out. List 1 is which goes directly to diabetes disease managers. First, their job is to manage anyone who has high A1C, especially is A1C about 8.5. And list of diabetes patient not seen in the ear. So they have protocols to manage insulin. So insulin there are protocols, they can titrate the dose, they can increase the dose, cut down the dose, and make sure that they make follow-up appointments. List 2 is for people who have high LDL and high blood pressure. These are, managed by, as per protocol, LDLs, the statins can be managed. They can increase the dose of statins, they can decrease the dose of statins. And, with all due respect to physicians, I don't mean to get it wrong here, but you don't need a doctor to manage statins nowadays. I think it should be, if you can buy, ibuprofen over the counter, you can buy a statin over the counter. But I think manage LDL as per the protocol. And, I'm sure I'm making a big controversial comment here, but I think, you don't really need a statin management thing. But blood pressure recheck, most of the time it's blood pressure is a recheck. Right now we just found 80 patients who went to urgent care for diabetic. Borderline blood pressure, we are getting big for them. We brought them, we are trying to bring them back or have a recheck of blood pressure when their appointment is done so that the blood pressure is normal so we can check that. And their job is to have no appointments, to again call to make sure that the people who have no appointments can be seen within 2 months. Now list 3, we just took it off from hands of any people. We're just trying to automate the whole process. These are the people who are missing labs, missing A1C, missing LDL, no appointments. What we have done is trying to do automated phone call system. And I think some of you know the telewalk system. So I think we have now is the Veroli system. Veroli system is an automated phone system which basically allows us to outreach the patient. And we are also using the web portal to send out messages, secure messages, the same as Kaiser or anyone else has a secure web portal. And I think the cost is very cost effective than having a person make the phone calls. So this is a very automated process. There are protocols, there are labs already placed into the system. People will already have, so suppose you're diabetic and you're missing the labs. You come the next time to the clinic, to the lab to drop off your urine for UTI. But the lab technician sees that you have diabetes, but you haven't had labs, the labs are placing it. They will go ahead and call the lab. So we believe that if there's something, it's better than nothing. So get the labs done at least. So this is the new automated system. It's a Veroli. Veroli is taken over by Nuance. So if you ever flown by Southwest Airlines and your flight was delayed and you got a voice message on your phone, that was basically managed by Veroli. So Veroli is now taken over by Nuance. But our new motto is minimize the number of lists which go on to the doctors and clinic side. So that's what we are trying to do. So that's our team work. So now we have on the team, we had on the team physicians, diabetes care managers, care specialists, and clinic staff. But one part which was missing was for us is to add pharmacists and pharmacy tech. And pharmacy is, very important for us. I think, they're really important for chronic care disease management. They align with the Right Care Initiative. And I knew that if I couldn't leave this room, if Marilyn was sitting there, if I didn't mention the pharmacist. But pharmacists are a very important part of our care delivery, and I think I'm going to show you some of the things. So this is our team. Ron Koch is our internal physician champion, and diabetes. This is the diabetes disease team who does a lot of the work. So they are really great. So here's a question for medications. When you come to medications, for the audience, among elderly patients who were 1 week post-discharge from the hospital, what percentage of medications were not taken at all? Excellent. Very good. I think you guys are stars, making it past everything. So 60, yes, you're right, 30% of the medications post-discharge are not taken. And I think we looked at the cost. The cost of diabetes was mainly coming from hospitalization. And many times people are prescribed medication post-discharge, post-transition for diabetes, and they are not taking the medication. So 30% of the medication prescriptions are not taken at the time of transition, and this is where our medication therapy management clinic, the refill clinic, and I think this is not new. This is, everyone knows about refill clinic. I think Kaiser has done it, Mercy has done it. So a lot of people in this room know about medication refill clinic. And there are standard, they do refills on medication, pharmacy, fax, they call in, patients call in, the messaging, and they're around all the 18 clinic locations for 115 primary care physicians. So they are providing a great service, and I think we are hiring more and more pharmacy technicians to really help out our pharmacists in doing that. But the next thing which we have taken, that's why I don't like to call it refill clinic. I don't like the name refill clinic. So we are trying to call it medication therapy management clinic, where we have now the second step, which we are trying to do is to have anti-hypertensive protocols. So when a pharmacist sees a medication prescription, for her blood pressure, they have the standard this protocol. They look at the strength, dose, when was the blood pressure checked, so that before we fill automatically medication, there is one more pair of eyes, looking into and bringing this. And I think Right Care has done a very good job of educating on this part, so I don't want to spend time on that. So when we were at this stage, when our performance was going down again last summer, this was, we started a centralized process. But the question came was, we had reached 48% goal. The question is that enough? All this thing, registry, physician engagement, medication therapy, is that enough? Is this enough to really get to that place? So, because you can hire as many people as you want. If you have support, if you have plans, you can hire people. You have diabetes disease manager, specialist staff, pharmacists, and you have a team. But how do you know how effective are they? And that comes down to the whole team-based culture, how the teams interact. So here's a question for the group. One effective way to engage patients in self-management of their chronic disease is make sure, these are the, what do you think your best answer is? Very good. So I think most of you have responded. Wow. Very good. I think, did you guys have a talk on this topic last night? If you had the talk, I just want to talk to the one person who missed the answer. I think that's amazing. Very good. You have. Yes, I think presenting yourself as part of the care team is very important. I think even the whole Partner With Me campaign I think giving all the instruction in one session is not worthwhile. Giving step-by-step wellness plan is very good. I think, if I'm a patient, I think I'm more engaged with you. If you project yourself that I'm part of a team, I work with your PCP, I work with your office, I have access to your EHR, I can look up things. That's why I think one of the things when you ask, what are the things we should do to really, I think having a EHR or EHR-like capability across the system is very, very helpful. Face-to-face interaction really always helps this thing. Patient-specific education material, rather than providing generic education material, create, and I'll show you some examples of that. Shared care plan, medication adherence, and forming the personal connection. And I think this is my, as we go into a new ACO relationship, we signed recently 2 ACO relationships contract. I think more and more health plans are acknowledging that, having your own case managers and giving your case manager PLP helps you to bring, the closer you are to the patient, the better engagement rate you have. So my appeal is always that let's, all these third-party vendors which we had all these years, I think who are sitting in Texas, managing patients, I think it doesn't work, it doesn't, and I think all of you know this, I know some of you have to do this as part of your regulatory thing. But I think the more closer we are to the patient, the closer people are, the better it is. So these are some of the examples of, and I think there's going to be never, for 17,000 diabetic patients, we'll never have enough people to hire. I can never hire enough case managers, enough nurses. And these, till patients are not involved in their own health care, patients don't drive their own things. These are some of the examples which drive patients, and patients will largely produce their own results. And some of the key elements, I think these are the things which we touched on just now, but shared action plan, face-to-face visits, proactive case management, follow-up check-ins, those are the things. And here's an example of a shared care plan which a nurse or physician can use to sit down with the patient and patient can say, okay, what should be my target blood pressure? What are the complications of diabetes? They can fill out, what your goals are, how are you going to reach the goal, and what are the things you can do to really, really improve your own health care. And there is some way we have to measure this. I think we haven't done, there's something which is still a topic, which we have to look into. How do you measure patient engagement? You have this team of people, if they're calling, how effective are they? So what we have started doing is in some way starting to measure this, how many people do interact with our case managers on an ongoing basis. So for that, here you can see it's, you might think only 36% of chronic disease patients are engaging. Well, if you look at the literature, in fact, that's very good. 36% of engagement rate is very good. If you look at, but we're not satisfied, we want to get it to 45% engagement rate. And the second thing is, I think, about healthier living classes, which are based on the Stanford model. I think a few years back at University Best Practices, we learned about how you can, what the success and challenges, have you invited them. And there were 15 workshops, almost 63% of them completed the workshops. I think that's great. In San Diego traffic, people are going every evening and attending classes. I think that's amazing. I just think the workshops are helping. So I think we have to get more of this. The lesson learned here is that we have to start measuring patient engagement. So by doing all those things, registry, physician engagement, patient engagement, I think we would, this is how that process helped to bring the control up. And today, almost 52%, and I think we're happy to report that, going forward, it's still on a flat, it's still at a high rate now. So, but this, this is not a smooth journey. It doesn't happen that everything you start programming, one time you start, it just goes up. You can see that we had 2 times, significant variation in our performance because of external factors or internal factors. And we have to address the variation. We have to look at what works, what does not work, and do it again. And I think it does take some willing to do it, but there are things to do that.
Can you go back to that last slide? And you see that the dip is happening in, it looks like March, April? Is there something happening there? Is that going to happen every year?
No, we hope it's, I think it's the post-Christmas phenomenon. No, I think it's because, if you have a process which is not really hardwired and you just scramble at the last minute, then I think it gets, but I think you have to do more things. I think what we are trying to do now is with all these changes, this process, that we want to hardwire this process and won't have it make it more centralized. And I think because of that, I think we're still seeing, we haven't seen it yet now. So I think I have this whole slide, but they haven't seen it yet now. So I think that the point is that if it didn't happen, you have to always realign and reassess and see what can you do differently. What are the things, are the processes working or not working? But the other topic I want to take, as we go forward for people who, for your groups or for your clinics who are still, hesitant to do it, or what is the benefit of doing this? I do understand change is hard. Change is very hard. I think trying to change your traditional style of practice and looking at it is very hard. But there are so many drivers of change which are coming, and mainly driven by CMS. CMS is driving the incentives and penalties, and rightfully, till now the incentives sometimes 1%, 0.5% were not enough. Really, I think you spend more money on than the incentives. But if you start adding your incentives and penalties in the next few years with EHR being introduced and everything, it's almost going to be 5% of penalties you're going to do for Medicaid charges, which is a big thing. And I think the same thing is being applied by healthcare exchanges. I think through your for commercial plans, everyone is looking at these measures to see how they can really improve population health. So when it comes to measures, bundled diabetes care measures, what do you think is the right? And the correct answer is yes. I think only Hattie answered number 1.
I thought Hattie would vote for herself.
But you're right, it's part of the IHA P4P, Medicare Star, CMS ACO Meaningful Use, PQRS, and SGR Fix. And I'm not an expert on SGR Fix, but I think what I heard last was that the SGR Fix in the future to reduce the Medicaid, fix the Medicaid payment, it's going to all combine. And I think when they combine, your incentives will be almost 8% if you participate in all this program. I think Dr. Hans, you can probably speak more. I know there's a bill out there, but you can speak more about that part. But it's a big, big thing. And it's not only in California. In fact, you'll be surprised. I think, when I was looking at it, Wisconsin and Minnesota do a very good job with their diabetes care. And then Boston has the whole AHQ contract of the Blue Shield on Massachusetts started looking at those parts. So I think, I know Dr. Pharmacist can speak more about other states, but I think, is it in Arizona also? Diabetes care is part of the quality measures? Yeah.
Yes.
So it's part of this, and now but this is, healthcare reform is, we have to leverage it somehow. It's all moving to value-based payment. Till now, we were getting check from P4P, we were getting this $1 million check. Here's the P4P $1 million check based on your performance and clinical quality. It's not happening now. It's going to happen is that it's all value-based payment. Quality measures will be gated in. So once the quality measures you perform, you can do excellent on quality measures, but if you do poorly on total cost of care, the total cost of care, you are not going to get any money, and your value-based payment, So I think even for P4P program, quality measures is becoming gated in. It's the same model we use for ACO, commercial ACO, PPO, say Pioneer ACO. The quality measures are gated into the value-based payments. So payments might increase if you do very good, and if you don't do very good, you can lose also. But here are the things, alignment of clinical quality measures. Every program, when you go to physicians, you don't tell physicians, oh, you treat one patient differently than other patients. Physicians don't react very well when we ask them to do different things for different patients. But thankfully, over the past couple of years, all these programs are aligning. You have reporting for diabetes and intravascular disease for PQRS, for ACO, for HRSA, Medicare Stars, and you can choose them for meaningful use also. So there is a whole alignment of clinical measures, and it all comes down to how we can provide value-based purchasing and reduce the total cost of care, and reduce by doing so by reducing complications. So what is, for the diabetes, if you, dialysis, top two causes of dialysis, people on dialysis is diabetes and hypertension, correct? So what is the average annual end-stage renal disease cost per patient requiring dialysis? So the average annual cost is actually $70,000. This is based on the kidney test, U.S. National Kidney Urology Clearinghouse. Almost $70,000 per year is the cost of patients on dialysis. Huge. And so by using that, to reduce the complication, that sharply we looked at some internal data on our diabetes performance to show the ROI. I just want to make a very disclaimer for all the researchers in this room. This is not a really randomized controlled trial. Don't take me to court on this. But this is just an internal tracking tool. And I think when we look at it, I just want to run by it. Our goal is to reduce the RCI growth, which are to reduce heart disease, stroke, and associated complications. And the left-hand side is the new complications per thousand from, let's say, 10,700 beneficiaries. And for looking at acute MI, renal failure, and retinopathy. And in a way, somehow, people do get randomized a little bit, controlled and uncontrolled. And you can see it's almost an equal distribution among them. You can see the distribution between acute MI, renal failure, and retinopathy. And what was the reduction in complications for each of this. So for example, if somebody is well controlled in this thing, the new diagnosis of dialysis was almost zero in this patient. So the cost avoidance, I think you can just look cost avoidance, it's not really cost saving, it's cost avoidance. It was almost 360 for MI, 210 for dialysis, 107 for retinopathy, and this was very, very conservative. If you think about Avastin, I think, Jim, I don't know, but the cost of this Avastin for eye is $11,000, but I just use $2,000 here. So you can now demonstrate the ROI internally to show that this is not just about HEDIS measure, it's about reducing the complications of the disease and reducing the burden. That's the ROI. Because it goes back to the one thing I learned in Sacramento is the water principle. It's not about competing with each other, it's really truly competing about the disease. So the lessons learned, for us, I think in this presentation I just try to show, we have to align stakeholders, look at the workflow, team-based healthcare, patient engagement, healthcare reform, total cost of healthcare, and change is hard. The things which we want to share with you, it's all about sharing, it's not perfect, and I don't agree, is that first let's get it on the organization scorecard. When it goes to patient care workflows, let's keep it simple and centralized. Team-based healthcare, who's on your team? And the new members are the pharmacists and pharmacy techs, who should be part of chronic disease management. Patient engagement, let's find some way to measure it. And that's something we have to look as we go forward. There's no perfect science right now, but I think that's something as a group we have to look at. Healthcare reform, let's leverage it. There's so many things going on right now which we can leverage in the group. Total cost of healthcare is to how do we demonstrate the ROI. And change is hard. And I think personally for me, I think, when things are not going good in the group or people are, things are upset or something, I think I look at this kind of network, this kind of UBB support, whether in San Diego, Sacramento, CMR, CHCL, is to see really to provide the support. I think anytime I attend a meeting, I get one point which I can take back and implement and look back and see how we can improve. So this kind of network meetings are very helpful. I know they take a lot of time, but I think we really learn and we are really trying to improve from this kind of networks. So in the end, I just want to say that it's really it's work, but I think I think about diabetes. Diabetes management is, for most part, it's not very hard. If you exclude people with type 1 diabetes, brittle diabetes, or you exclude people who are post-brittle surgery insulin management. But for most part, type 2 diabetes management is or it's simple. Many people know about it. It's not simple, but many people know how to manage diabetes. It's just getting the patient engaged in their own illness, checking on them to see if they're taking the medications, and even driving home those points. So I just want to drive home that point with this one clip to show you.
My asthma. They said they'd fix it, but it didn't make any difference at all. My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, and you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So I think with that, I just want to thank you for thank you for your support. And if anything, questions, I'll be happy to take, or you want me to do it later on?
No, I think we should just carve out at least a few minutes for questions. I know that there are probably a lot. Yep.
What proportion of your practice is capitated versus uncapitated?
Let me answer this way. 70% of our revenue comes from capitation.
Any other questions?
Well, I try to keep it very simple, so I think
I
it's
have
that question.
a question. There was a slide where you had various disease states, and then you showed compliance with interventions. Could you go back there?
This one.
So, as I look at that slide, the overall it's 36%. Obesity is under 10%.
Yeah.
Are you thinking about focusing on that patient type, or
So
because the rest of them are all double digits?
right. So this is not. I think we are trying to phase in this report. We're looking at the obesity in a different manner. So we were trying to do this. This was mainly obesity with sleep apnea patients. But what we are trying to do is, we have a different obesity program, so I think I have to take this out of here. We have a different obesity program on weight loss. So there's a weight loss clinic, weight loss. Yes, we have obesity program. We look at this. This was a subset of different kinds of patients, so I think that's not correct here. It was mainly to look at sleep apnea patients.
Oh,
And I'll tell you one thing, obesity and sleep apnea, trying to reduce weight for those groups is very, very hard.
I really appreciate your talk, just a great story, a lot of lessons learned. Could you say a little bit more about the physician culture? You explained that there's some 100 quality metrics. This isn't certainly the only quality improvement project, but by many scores. Physicians reacting, the 10-minute appointments. Did you use physician champions, kind of the official hierarchy, or some combination? Or did it more of a grassroots with kind of the team building enthusiasm that we know, managing physicians like herding cats?
I think it's a very good question, and I think I'm trying to see where I can start. But I think, one thing is, I think it comes from the whole, first is, the physicians who are hired into the group have to follow the group philosophy. So the group philosophy is that the patients come first, the group comes the second, and you come last. So I think anytime a decision may be struck, what will we do? I think, the patients come first. So I think any time in the leadership meeting, the board meeting, or in the council chair meeting, that's how decided. The second is, I think, the group has over the years, I think it's, I won't say everyone, but the vast majority have accepted that they can't do everything themselves. I think they are willing to let go of certain things and allow their nurses, their processes to outreach patients. And sometimes, you don't hit 100% accuracy in those, but it's okay. My job is really to, when anytime somebody complains that, why did you reach out with this, blah, 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 it's my job to go there and meet with them and explain them the process. So I think we are, trying to go more towards doing things to make sure that we catch everyone rather than being a truly autonomous, maybe we want to give autonomy to physicians, but it's also a group culture, and that there are other ways to also reach patients. That's one thing. Third is, I think, alignment of payment. I think we are trying to align more and more payment and physician compensation package towards this thing. And that's not a small, that's a big factor in driving things.
Yeah, I would just say that Gary Kaplan at Virginia Mason Hospital, which has gotten a lot of attention for improvement, gave us a similar answer that we start by hiring physicians who have this team-based approach to care and patient first. And if that's not in alignment, then they're asked to leave. So it starts with, as you said, a culture at a group level.
Yeah.
That's helpful. Thanks.
Was that slide that you showed the variation between the different physician groups in terms of how well they were performing? Was that at the onset of the project, or was that when you actually reached 52%? You had one slide early on that showed all the different groups. I guess.
Yeah, no, it's an ongoing process.
So what I wondered though is, over time, as you've gotten to 52% now, have you seen a decrease in the variation between practice sites, or do you
Yes.
still have as much variation?
No, I think there are still some physician, very small group of physicians and their own practices which are still low performing. But I think the variation in different practices is going down because of a lot of the centralized process which we have instituted.
Great. Well,
Very good. Thank you very much. And